Welcome to the On Your Mind podcast, where we believe mental illness can be temporary and transformative. Stay tuned for innovative, effective tools from experts in the field of mental health. Hosted by Timothy J. Hayes, psychologist. This podcast aims to change the narrative around mental illness. Move from a place of fear to a place of hope and solutions. Here on Your Mind.
Lyle Murphy is the founder of Alternative to Med Center and has been with the center for 16 years. Lyle did his pre-med scholastics at West Georgia University, receiving the only recommendation for advancement to medical school in his class. Though accepted to Emory Medical School, he instead chose to attend Life University School of Chiropractic because of their naturalistic approach. Can you tell us a little bit about how you got into the work you're doing and what drives your passion for it?
I mean, anyone who takes on a purpose like this has probably experienced their own pain. And tragically, I did. I was in chiropractic school. Actually, I had been accepted to Emory and after my pre-med and decided to, I read a study, I don't know if it was a Harvard study, but it was a study that compared the top 20 disease processes and the top 20 drugs for those disease processes and showed that a placebo was more effective in all 20 cases. And that sort of ruined my perspective on being a prescriber. And I didn't know anything about chiropractic when I went into it. I just knew that it wasn't being a prescriber. Now, in hindsight, it would have been good for me to complete a medical education because then I could change the medications, but I didn't have any idea of what was to come. I got all the way through chiropractic school and I was literally a starving student. I didn't have as much support, as some of the other kids to be able to finance their education. And in truth, I had a bit of a drug stint for 9 months in there, right at the end of my education that I had recovered from, that had depleted my finances. And I got right to the end of my education and went into hypoglycemic shock and literally was in a coma for 2 weeks. And when I came out of the coma, I had an IQ of about 4. I couldn't talk. I couldn't ambulate if there were other things like cars moving around me because my proprioception was off. I couldn't hold a conversation, even after I recovered my articulation ability. I couldn't hold thoughts in my head long enough to remember what we were talking about. So literally, if I was to tell a story like this story, I would forget what I was talking about in the middle of the story. And that persisted to some degree for 10 years. Another icing on that cake was I had called for help because it was during the winter break, the Christmas break for school. I basically at that time was homeless because they would close down the dorms and everybody would leave. So I would be, trying to survive outside. And in Atlanta, where I was, it was really, really super cold. Anyway, I called a friend for help. A car just like his showed up in front of the phone booth that I called from. And I went and sat in it, and it turned out to be the wrong car. So when I woke up 2 weeks later, I was in a jail hospital. I'd been charged with a felony. I was tied down to a gurney, and I didn't know what had happened. I had no idea what had happened. And I was in jail for another 3 weeks. By the time they propped him up in front of a judge, the judge, I'm on Haldol at that point. And the judge is like, "Are you sure you want to accept a felony for this?" And to me, he was saying, "Do you want to stay here or do you want to go home?" And obviously I wanted to go back home, but there was really no going back to my life. At that point, I had a felony, couldn't be a doctor. They charged me with unoccupied burglary for sitting in a car, if you can imagine. And I didn't have the wherewithal to explain my situation. So fast forward 10 years, I'm volunteering at a drug rehab, and they had a sauna program, and they said, "Hey, why don't you do the sauna program?" And it was a lot more than I had ever done in 10 years. It was a lot of dedication, and somehow I managed to dedicate myself to that. And after 30 days, I literally just woke up like I'd been asleep in a brownout for 10 years. I just woke up. And I had all my faculties about me, could remember my medical education, and decided there's probably other people that had been put in a situation like myself that had been mishandled. And so I really got into the blood sugar thing at first, trying to help people figure out if they had a blood sugar issue. And by and large, about 74% of people entering into a acute psychiatric emergency room have at least a blood sugar component, something called reactive hypoglycemia, where you eat sugar, then you overdump insulin. The overdump of insulin causes you to actually drop below baseline fasting blood sugar. And for a couple, 3 hours, you're in this place where you're unstable. Not that there aren't other contributors to why people end up in the hospital, some emotional upset at their house, but it sort of crescendos those situations to be more unmanageable when the blood sugar is unstable. So that was my first approach into helping people. Then I got hooked up with the orthomolecular crowd, fellow by the name of Dr. Michael Lesser in Berkeley, this old Jewish fellow who looked like Moses. And at the time I was working with largely schizophrenics, people that hadn't seen a bright moment for a decade or more. We started applying these orthomolecular principles, which was high dose niacin, high dose vitamin C, things like lithium orotate, running neurotransmitter tests to see what people were deficient in. There was some efficacy to that. There was some big recoveries, I guess you could say, but honestly, the success rate was about 25%, which with that population was actually quite encouraging because they were throwaways, But it wasn't really enough to create a center and say, hey, we're doing this thing. So I got into environmental medicine because it just seemed rational that people might be poisoned, and that maybe the poisons are intersecting with their ability to be able to synthesize good brain chemistry. And that took us a long ways. Working a detox program where people are, there's a natural process in the body called biotransformation, where you take maybe a neurotoxic compound and you have to transform it out of the body. So we were accelerating those underlying physiological processes, got into testing people's genetics to see where some of their genetic vulnerabilities might have been, and stair-stepping around some of those things. That's where we really started hitting the jackpot with people. Since then, I've been into this now for 16 years. I have a staff of about 50 people. We're licensed by the state, able to take insurance. We're just now completing JACO certification, which is an accreditation for hospitals and residential facilities like ours. There's a great structure around the spiritual aspects of the program, the psychological aspects of the program, and the physiological aspects of the program. And even as an MD, if you were an MD, or even as a therapist like yourself, there's certain limitations that you have an outpatient to navigate someone through the depths of what they're going to go through in a psychiatric medication withdrawal. There's other components. They need good counsel. They need someone who is a good strategist around how to do medication tapering. And then they need someone that has an understanding of the innate wisdom of the body and can work with that in a way like a naturopath can. And to find that all in one person, especially in an outpatient setting, where you really don't know what's going on with the patient for the other 167 hours of any given week, if you're seeing them an hour a week, to really pull it off. So the residential collaborative model that we have is effective by design. I have at times been lured into outpatient work, but I've never really been truly successful there, because there's just too many variables to try to confront and to try to understand in order to move a person and to hold the space for them that's necessary to do this. Because there's not a lot of understanding about discontinuation syndromes. We talk about alcohol. When you go on a bender or you've been on a bender for a while, you're going to have a headache. You're going to have possibly seizures, deliriums. Your B vitamins are deficient, and there's a straightforward path on how to deal with that in the professional medical community. There is absolutely no conventional wisdom around psychiatric medication withdrawal discontinuation syndromes and how to mitigate those. There's pockets of people who know how to do things, but there's nothing really orchestrated in a way that the conventional medical paradigm can utilize.
Well, and you're talking about withdrawing from psychiatric medications, and there are people who say you don't need to withdraw. You just stay on this the rest of your life. And those are predominantly medical people, psychiatrists, medical doctors. What you're tapping into here is what Whitaker's book about anatomy of an epidemic and Peter Bregen's work would point us to, is that a lot of those medications, whatever short-term efficacy they might have a lot more negative long-term effects. And so it's important to get people to withdraw from them and find different ways to actually get the body and the brain functioning. How often do you get people who are surprised that you want to get them off the medications?
In the beginning, everyone, 16 years ago, there was just no buzz about this. But now there is. People recognize that there's limitations to these medications, and that they have an awareness that there are alternatives, but they don't know where to find them. And to touch into the argument around, you need to be on medications for the rest of your life. If I had the scope, if my window of peripheral was seeing a patient once a week or once a month, to be more real about how often a psychiatrist sees their patient, and that was my exposure to their life and the influence I had in their life, and they weren't making any other changes, and I know the withdrawal manifestations are going to go through if they stop these meds, it would be absolutely logical for me to believe that and not want to take responsibility for taking them off their meds if they're not making other changes in order to accommodate that. For most people that come to us, I don't have people generally calling me saying, hey, the medications are working great, but I want to get off of them. I mean, sometimes a woman wants to get pregnant and she feels like the medications are going to have been working to the degree that they're satisfied with the quality of life, but they know that particular drug has consequences for the unborn. But most people are not satisfied with what's going on with them. And to look at it really dichotomously, to really like you're either on meds or you're off meds. So on meds, it means you've controlled certain symptoms and you have certain side effects. Off meds means that you have those symptoms without any buffer of support. That's how most people see it. It's either this or it's this. Well, the strange thing is that the distance between those is a lot wider than people are aware if they insert certain things. And it's a lot, it's a very difficult path. It's not like even drug addiction. It's not even like heroin addiction. These recreational chemicals are a lot more crude in the way that they manipulate the neurochemistry. Some of these drugs are very prolific in the scrambling that they do and the neuroadaptation that occurs in response to them, and to navigate that without any wisdom. Yeah, I can see how most people would think, yeah, I need to stay on these medications for life. And I empathize with that. There are people that even with our lens, that may be true for. If a person doesn't have the means, either because of their cognitive abilities or because of their support systems that they have, in order to clean it up a bit and get their body moving, eat better food, use supplementation, have an environment that is free enough of emotional chaos that they can actually have a fulfilling life and they have a better quality life because of the medications. A good example might be one of my personal challenges is that our medical model is set up that if someone goes psychotic, they get taken to the hospital. Not all states, but some states are more aggressive than others, titled and forced psychiatry. Well, what's the option? We don't have a option in our society for someone to be in a manic or psychotic state and not get hurt or jump out in front of traffic or think they can fly or have someone that can attend to them for the amount of time that it would take to naturally push through that. Most people in a psychotic state, if they have intermittent psychosis, if they're not, organic brain damage and they have periods of lucidity and high functioning mixed with being a train wreck, in those manic states, they would push through them if they were given the right environment where they could not hurt themselves or hurt anyone else during the process, have someone be with them and have them eat when they can, if they can, food that actually supports mental health. But there's not that plan B crucible for people to jump into. There's only this acute stabilization model. The biggest leap to pull those two bookends together between the what can be done without drugs and what is done with drugs is how do you handle people in acute psychosis, like where Journey was at.
I'm assuming that what you offer at Alternative to Meds is an answer to that question.
Not quite. We're not licensed to take people who are in acute psychosis. Usually when someone's presenting unstable, that's not the time to do large medication changes, that may destabilize them further. There are certain people who are reacting to especially antipsychotics, that are making them psychotic. There's a certain presentation for that. Like they were drug induced and not feeling themselves and disassociated. They went to the hospital and they got an Abilify shot or something, and then immediately went psychotic. Those people probably need to get ripped off of that and be in a place where they can stabilize. But most people that are acutely psychotic, we don't have it's Alternative to Meds. We don't have a mechanism for that. They have to be in a stable place, and then we do things gradually in a way that doesn't destabilize them. But there is not an acute, that I'm aware of, there's not an acute care lockdown situation that can put someone in a place where they can't hurt themselves or others and just work through it.
So that's another level of building a health system that you see needs to be done.
Mm-hmm. Yeah. Yeah. And I am considering what that might look like. I don't want to be the one to put somebody on meds that's never been on meds before. If someone were to get acutely stabilized with medications, I'd like to run a genetic test on them first and get some kind of an idea of what they can tolerate and what they can't. If I had any input on the design of this thing for the world, it would be, these tests are available. They may not be perfect. The genetic tests give you an impression. They don't give you a complete, this is the roadmap that you must follow. But it's something. If you can see somebody's got genetic pathways that are not going to accommodate that drug, don't you think you'd want to know that before you force that on somebody?
I keep thinking of Inner Fire in Vermont, which is a residential program for people that they want to have the option about how many meds to take and how much and whether or not to get off of them as they go through their mental health challenge. This residential center was begun by a woman who was an art therapist and was over in Europe, and she was just shocked when she came back over here and realized not just a few people, but everybody is given meds. She said, over in Europe, they don't do that. They don't load people up with meds. And yet they aren't losing people left and right over in Europe. So there are ways to do this, to help people with their acute crises without just loading them up with meds.
I'm sure you're familiar with the Open Dialogue project that's been going on for 35 plus years over in Finland. I'm giving you sort of secondhand information that I got from a fellow named Kermit Cole, who's one of the Open Dialogue therapists, and gave me more of the history of it. Essentially, my understanding is that rather than have drag you off to the hospital, tie you down, force inject you, the culture in that area of the world at the time was more geared around the psychotherapy. And so they're like, well, let's try to have an open system here where we look at the individual as being a collective of the influences around them, and let's get everybody talking. so that we can understand what their crisis is and work at it from a non-drug angle. And they ended up being the most successful model for schizophrenia in the world. And their country, I believe, has about a tenth of the number of diagnoses of schizophrenia compared to other parts of Europe because of that. And this is something I wanted to touch into because of my own psychosis. That's sort of my, those are the people I love the most. Well, I mean, I love everyone, but I have a certain affinity with the people who have experienced psychosis. I get it. I get what's going on in there to some degree. There's certain meds that are worse than others, right? For the majority of people. And one of them is the antipsychotics. Strangely enough, we've crusaded against the opiate crisis. I say we, I mean the medical community has. And there's at least some awareness around the benzodiazepine problems that people have. And there's some legislation on how much to prescribe and what other drugs you can prescribe with benzos and how long you can prescribe them in certain states. But really, nobody's touching into this antipsychotics. I mean, getting somebody off benzos, and I've seen people who have struggled for decades. It's still not the same struggle as antipsychotics. The amount of neuroadaptation that happens in response to antipsychotics is profound, because one of our major gearings is to be alert and attentive and to understand our position in space. If our head is level to the horizon, if our spine is erect, and dopamine is involved in that, along with norepinephrine and acetylcholine and other stimulatory neurochemicals. When you shut off the ability for your body to get stimulation from an antipsychotic, you're shunting the amount of dopamine that's available. Your body is very creative at surviving, because you not being aware means you could step off that curb and hurt yourself. It means that the rewards in life are not going to take you to a survival place. And so there's this phenomenon called antipsychotic-induced dopamine receptor supersensitivity. There's and if you have a link to, if you have a way to share links, I'd love to share this link. The full article would need to be purchased, but you can get the abstract through the link. But basically, these researchers, Martin Harrow and his colleagues, followed schizophrenics for 20 years that had been either medicated or not medicated. And they took out different confounding factors like severity of diagnosis, because you would naturally think that people who were not medicated for that long period of time didn't have a severe symptom. So they equalized based upon that. And they found that the people who had been taking antipsychotics long-term, over 2 years and up to 20 years, were 6 times as likely to have a symptomatic relapse. In other words, about 13% of the people that were getting off the meds were getting rehospitalized, as opposed to how many of the others. 6 times, it's 600% more. And that would naturally lead anyone to think that the antipsychotics are creating the problem.
Or psychosis, yeah.
Yeah. So they believe, we believe, based on what I've seen, that it's based on the adaptation that happens in response to these meds. So you essentially get dopamine receptors that have been starving for dopamine, kind of like I have a roommate that's really into iPhones, and when the iPhones come out, everybody's like, that's how these receptors are, like the people standing out in front of the phone store waiting for the iPhone to come in. When that dopamine comes in and hits those hypersensitive receptors, then a person tips over into psychosis. And that's the withdrawal effect of that particular medication that is unique and distinct from alcohol or heroin or other drugs. So you've got a situation where the antipsychotics are creating this tardive psychosis, this latent psychosis in people, and perpetuating their diagnosis. And so I have not yet found anything substantial in all of my research to show that there's long-term efficacy for antipsychotics. I've found plenty of information to show that there's a long-term detriment to antipsychotics. So we know this. The challenge is, how do you fix this problem? How do you fix, because when you take somebody off these meds, they're gonna escalate. And how do you do it in a way that's going to keep it in between the lines? And the harsh reality of it is if you're going to do it, it has to be done really, 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 really slow. You can't yank people off this stuff. I mean, if they were to get yanked off of it, they eventually would probably stabilize, but they might not survive it, because people in psychotic states obviously do things that might get them hurt. Yeah. So unlike antidepressants and even to some degree benzos, you got to go for the long game on this. And that's where a program like ours or a program like Inner Fire respects that, and creates a container for people and helps them to understand. And there's only certain candidates that are really good candidates for this antipsychotic withdrawal path. There's got to be some agreements with that person that it's kind of like driving a logging truck down an icy road. You got these switchbacks, and if you know how to drive the truck and you do it really slow, you can get it down the mountain. When you're taking off the antipsychotic, it's like pushing on the accelerator. And as long as you are a skilled driver and you don't have someone else grabbing the wheel while you're trying to get down the mountain, you can get down the mountain. But one of the challenges is that when people start feeling better, because this drug's been holding back their access to dopamine. Dopamine is the neurochemical equivalent of reward. And not having a reward in your life, not having any aspirations towards a sexual partner or a job well done or some sort of passion and purpose in the world, that's really, really, really debilitating to your psyche. And all of a sudden that starts to come back because you've reduced the meds. The tendency is to I don't need those meds anymore, and to just drive the truck off the mountain. A clear understanding with that person that they have a person that they can contract safety with, whether it's their therapist, their pastor, their wife, somebody that if things are going too fast, they'll take their direction and slow it down. If a person can do that, if they can do it slowly, they can generally get through it. But if not, it could end up in another hospitalization or worse. As I've seen things over the years, people who have intermittent psychosis, people who, strangely enough, people who stabilize on the medications are better candidates than people who don't stabilize on the medications. People who don't, if it works some of the time, if a person can function in the world some of the time, they're not broken. There's just something that's flipping the switch, whether it's the way that they overconsume caffeine, or they're pot smoking, or they're the medications themselves. There's factors that are creating the sort of schizoaffective type of disposition. A person who hasn't seen a bright moment in 10 years, has been constantly symptomatic, even on the medications, that's going to be a lot tougher. And there might be a place where there's still going to be those symptoms even after you pull the meds back.
Do you know of Peter Bregen's book, Psychiatric Drug Withdrawal?
Mm-hmm.
For the thing I like about it is it's a guide for prescribers, therapists, patients, and their families.
Mm-hmm.
And what he talks about in there is just exactly what you're saying, with the caveat that it really needs to be driven not by some kind of a formula, but by the constant feedback from the patient.
Mm-hmm.
Because there's a tremendous variation from person to person as to how much bounce back there will be, or rebound, or ability to stabilize at different levels of the medication. And it isn't something that most classically trained medical doctors can make sense of, because sometimes it's this, almost down to the molecule that we decrease the meds. And I've had
Mm-hmm.
patients who've been told by their psychiatrist that, well, that doesn't mean you're taking so little, you just quit. And they can't quit, because when they do, all heck breaks loose.
I wouldn't wish these antipsychotics on anyone, but I think a psychiatrist would be a better psychiatrist if they'd experienced some of these drugs that they're prescribing. Sometimes it is down to the molecule. There are things that do help. There are adjunctive things. Peter doesn't really, at least as of the last time I spoke or was interviewed by him, he doesn't do a lot with supplements or physiological components. And I think my challenge to that's actually quite simple, really. There's genetic pathways for how we break down drugs. We all have them. Sometimes the drug's not even an active metabolite until we convert it with liver enzymes. So these CYP enzymes drive how we metabolize a drug and clear it out of our system. And his focus has been a lot on tardive dyskinesia. Those folks have genetic reasons why they're not able to clear those antipsychotics that builds up in their system to toxic levels and has neurological impact. Well, those same CYP enzymes drive normal metabolism as well. They drive how much vitamin C does this person need? How much folate does this person need? And so understanding that and utilizing a person's own genetic hand and leveraging it to their advantage can make the process a lot more successful. For instance, one of the helpful bridges in antipsychotic withdrawal is lithium. And lithium carbonate, the real problem with lithium carbonate is the range between its neuroprotective effects and its neurotoxic effects is very narrow. And they have to do lab tests in order to figure out their range. But you don't have to use lithium carbonate. In fact, lithium is not equally distributed in the Earth's crust. There are places in the world where there's a lot more of that in the water. Well, strangely enough, in those places where there's more trace, we're talking minute, molecules, as you would say, parts per million, more in the water, there's less incidences of schizophrenia, suicide, and homicidality. So you can use supplementation for this, like lithium orotate, not at a toxic level, but that gives a person enough of a buffer to be able to help with the withdrawal. Some of the orthomolecular stuff that I dove into early in my career panned out, some of it didn't. But one of the things that does help people who are in psychosis is high-dose niacin and high-dose vitamin C. Those three nutritive elements alone, just the lithium orotate, the vitamin C, and the niacin are approachable enough to where I think most people can do it. On our website, if there's a way to share a link, I have an antipsychotic tapering and an antipsychotic alternative page that kind of gets into ways to help with a good pragmatic slow withdrawal. I see people, especially in our more, how would I say, technical world, isolating on their phones or video games or Facebook, social media. Not the best thing when you're in antipsychotic withdrawal, especially like a repetitive music, because the repetitive music is actually stimulating dopamine. When a text comes in on your phone, it's a little dopamine hit.
Yep.
It's better to get outside. If a person can actually build up a cardio program, because the things that help metabolize dopamine are vitamin C, oxygen, and lithium. So if you can get out running and getting your cardiovascular going, that's going to help purge some of that excess dopamine that's hitting those hypervolatile receptors in the process.
Well, and that's one of the things that I really like about whether it's an Inner Fire program or your Alternative to Meds Center program is that you're looking at the whole person and a variety of factors that can mitigate problems if you're coming off of medication and help a person, as you said, if you don't have a focus in life, you don't have pleasure, you don't have companionship, you don't have a sense of community or purpose, it makes it hard to have a happy life, to have a rewarding life. When you're looking at, I like the way Dr. Mark Hyman talks about it, it's not rocket science. What we need to have for healthy human beings is balance of food and water and nutrients and sleep, but also love and a sense of purpose and a sense of connection to community. And most of the allopathic medical psychiatric approach is just that one factor. Look at your behavior and, okay, well, you're missing some meds, and it just doesn't work that well for most people.
Yeah, and it's not rocket science, but then again, it is rocket science because we've been conditioned so strongly away from the basics that it seems too simple. Move your body, eat healthy food, and surround yourself with good people that support your beingness. And a lot of times that means somebody that understands the innate wisdom of the body, like a naturopath, or someone like yourself who's a therapist who can help give good counsel. But you got to get these. How did Freud say it? If before you diagnose yourself as being depressed, make sure you're not just surrounded by a-holes. The people around us have a lot of influence on us.
Yeah. Well, and there's all kinds of people that I deal with who have been so conditioned to believe that they are the problem, where in essence they're involved in a verbally and emotionally abusive pattern they can't extract from. But with a little outside support, a little identification, some good books that describe that pattern, and people wake up and say, oh my God, did this person have cameras in my house? How did they know that? Well, it's because we fall into patterns as people. We are creatures of habit.
Mm-hmm.
Well,
and the mind of a psychotic is actually very fascinating. When we don't have those other relationships, we don't have people that support these spiritual insights that we're having. It's the natural tendency to move towards the internal dialogue is there, because there God has a place for us. The spiritual unfolding of the planet might be happening through our brainstem, and that we're a part of this grand design that's all happening in our heads. And so when we don't have those other mirrors that are able to reflect back to us, like, hey, you are actually really wonderful, and being your friend and being around you is great, but I don't really think that everyone could possibly be following you on the planet, because look at that mom over there. She's got a job. She has to take care of her kid. She's worried about her own survival. She can't be part of this government plot to follow you around. I mean, you're important, but you're not really that important. And to give some proper reflection in those places, to have some wisdom come out of it. We did an experiment. One of the trends that we saw was people would go through treatment, they do great, they go home, and it was hit and miss. And so we said, well, let's try bypassing the entire residential stay, and let's go to their home. Let's send a team out to their home and get them set up in their own area. And the things that we found the most successful was helping them shop and helping them understand good food principles. Getting them to the gym or the Pilates or the yoga or horseback riding or something that was physically, active, and helping them rewrite some of the characters in their life. Get hooked up with a good naturopath, get hooked up with a good therapist. Those three things alone were almost as successful as the inpatient treatment. And it was in many ways that simple.
Well, and I think her name is Catherine Adams. We interviewed her, and she was talking about the importance of the early intervention for psychotic episodes, and that, wraparound approach, tremendous success. And then when people go back into their home environment, it can fall apart. So then they were working on, okay, so how do we do just what you're talking about? How do we get them set up with the resources within their home environment or their native community, so that the very things we're doing don't stop as soon as they leave our program or our residential treatment, and then they're flying untethered.
Yeah, we've affectionately called it in-home health invasion. We go in their house and we literally tip everything out of their kitchen, all the toxic hygiene products out of their medicine cabinet. Of course, not their actual medicines, but the toxic creams and the toxic hygiene products. If we're putting it on our skin, we might as well be eating it, because the fat soluble compounds that are in those, that the hormone mimickers and the endocrine disruptors and things, they're going to pass right through the skin and into our brain and into our nervous system and into our organs. Our skin's not a barrier for fat soluble compounds. That's why hormone creams work. You put a hormone on it, and helping them understand the things that you're putting in the home to replace it, and then getting them out to the gym just getting them on a routine where they're moving their body, and then lining them up with somebody in their area that you can hear that they understand enough how to do this. We have resources all across the country, some places better than others, but somebody that'll work with them. And that's a good game plan.
Yeah. Yeah.
Then having an app, having like some kind of an app where people check in. Did you take your supplements? Did you eat? Did you go to the gym? So you can keep following that they're doing it. And if you see 4 or 5 days that they haven't been checking in, you call them and say, hey, I see you haven't been, logging in. What's going on? Honestly, I mean, we have a great residential reboot program. The scientific savvy that we've achieved in 16 years and what we can do to tune people up is phenomenal. But the real playground is their home when they go home.
Yeah. And
if they're not set up there, they're not set up there. And I think that as we evolve this thing, you, me, Journey's Dream, other, points of light out there, having health coaches that can go to people's house and help them get lined up, get them on a forum, a weekly meeting where they can be in a Zoom meeting like this and talk and raise their hand and give each other guidance, support, camaraderie, peer interactions. All that is kind of the next frontier.
Well, it's wonderful to know that you're out there. An Alternative to Med Center is out there. You're in Sedona, if I understand.
Yeah. We tried to pick. In religion, they've noticed that aesthetics is a very high form of healing, which is the inspiration behind a lot of art. So we chose the most artful place we could find in the country to help people heal. What I'm looking at, you can't see, is just awestruck. And people don't need a gym here. They just go out there. And their spirit has plenty of room to take up as much space as it needs to. Yeah.
And so what is the capacity for your facility?
Well, we're at 17 right now. I do have some influence in the recovery world. There are people who want to take what we're doing and make it a lot bigger. So we did put an offer in on a property that holds 64 beds, 26-acre property. We'll see where that goes. But for right now, it's 17. I have a room that I could turn into a double and make it 18. We're actually licensed for 18, but we...
And you said you've got about 50 people on staff?
Yeah, it's a behemoth staff. I think I created the most complex, I don't want to call it rehab, but it's licensed as a mental health center. It's probably the most complex mental health center in the country. It's an environmental medicine, which deals with people's genetics, what poisons are out there, how those poisons interfere with natural physiology based upon genetic expressions, and how to actually clean that up in a mental health center. It was designed like that from the beginning, and then it was later licensed. And the licensing board was like, "What? We don't know if we can license you." I said, "Well, if we're holding on to people's meds, you have to license us. You have to give us a license to be able to do medication management." So they did, but they'd never seen anything like us before. They're like, "Okay." So it's a lot to manage. That's why you need 50 people. We're doing IVs. People are doing a physiological detox at least 2 hours a day that involve breathing glutathione, taking supplements to help biotransform out certain toxins, exercising, being in a sauna to sweat out these. Once you make the toxins water soluble, if you can open up the skin to be another elimination pathway, it helps them kind of wring people out a bit. But it's not just sitting in a sauna. There's a whole application process for what you're doing.
Well, it's a pleasure to be able to interview you. I appreciate it. I'm looking forward to following you if you get an extension and expand to 60 some beds. And I really enjoy skimming through the website. And as you say, you've got articles there about how to get off of benzodiazepines and anti-anxiety agents and antipsychotics and antidepressants. So it's a wonderful resource at alternativetomedcenter.com or alternativetomeds.com.
Mm-hmm.
Is that the right
address?
Yeah,
alternativetomeds.com.
Yeah. So thank you so much for taking time to be with us, and I'll look forward to following your work.
Yeah, and if there's any like future overlap, one of the things in 16 years I've gotten particularly good at is the actual medication withdrawal piece. Which meds to withdraw when with the polypharmacy, like which medications to go after first, which ones to go after last. And I have a high interest in teaching others that. It is truly uncommon knowledge. And, they can bring patient examples. They can hit me with anything. I figure if I'm helping the people who are then helping others, that I can get a lot deeper than just the one patient at a time thing.
Excellent. Well, thank you so much. I appreciate it. It's been a pleasure, and I look forward to following your work.
Thank you, Dr. Hayes. All right.
Take care.
Appreciate the time.
Lyle Murphy is the founder of Alternative to Meds Center and has been with the center for 16 years. Lyle did his pre-med scholastics at West Georgia University, receiving the only recommendation for advancement to medical school in his class. Though accepted to Emory Medical School, he instead chose to attend Life University School of Chiropractic because of their naturalistic approach. Immediately after completion of chiropractic school, Lyle suffered a low blood sugar event that resulted in a crisis. Hallucinating for no known reason, Lyle was justifiably concerned and went to the emergency room. While at the hospital and trying to differentially diagnose himself, Lyle insisted on a blood sugar test as it seemed the only logical conclusion. The result was deathly low blood sugar levels. Instead of the hospital appropriately treating an obvious medical situation, he was instead given a Haldol injection, and soon after dropped into a low blood sugar coma for 2 weeks. He suffered stroke-like residuals and had to relearn how to talk, walk, and communicate all over again, without any professional help or hope. Still highly impaired after 10 years, and looking forward to at best living a disabled life, he made a full recovery after engaging in some of the modalities similar to those offered at Alternative to Meds Center. This gave him a potent exposure to how inadequate the mental health system truly is. Lyle has now dedicated his life to holistic mental health and furthered his education to receive a postdoctoral certificate from Spirit Med in environmental medicine. He trains doctors in medication reduction techniques and has authored much of the philosophy of Alternative to Meds Center.
You've been listening to the On Your Mind podcast, offered by Journey's Dream, where we support people through mental health challenges to a place of true and lasting well-being. If you love our show, we invite you to visit onyourmindpodcast.org to join the conversation, access the show notes, and discover our helpful resources. Thank you for listening.